We present a robotic-assisted neovaginal creation in a patient with Mayer-Rokitansky-Küster-Hauser syndrome. This syndrome is the primary cause of vaginal agenesis. A 27-year-old female patient diagnosed with MRKH syndrome at 18 had normal external genitalia but no vagina. On the left is the pelvic MRI of our patient, and on the right is that of a healthy female. Both images show the rectum and anus, but the patient's MRI lacks the uterus, cervix, and vaginal structures. According to the ASRM 2021 MAC classification, was diagnosed with MRKH syndrome, consistent with the subclassification of uterine remnants without functional endometrium. The patient attempted vaginal dilation, but it was unsuccessful due to intolerance. Considering the treatment algorithm, vaginal dilation may be preferred for sexual function, and surgical methods can be considered if vaginal dilation is insufficient. Consultation was provided to the patient, and the option of redilation was offered. However, the patient opted for surgical treatment. For our patient's treatment, we planned a robotic-assisted Davydov procedure. The steps of this technique: patient positioning and port placement, identification of anatomy, dissection of the rectovaginal and vesicovaginal spaces, creation of the neovaginal canal and peritoneal flaps, formation of the neovaginal introitus, construction of the neovaginal vault. Pelvic examination reveals a shallow vaginal dimple. 2 grams of cefazolin were given an hour before incision. Bowel preparation was not performed. A 14 French Foley catheter was placed preoperatively, 4 robotic trocars, and an assistant port were inserted into the abdominal cavity. The Da Vinci robot was then docked to patient's right side. The absence of the uterus, along with rudimentary uterine structures, tubes, and ovaries, was observed bilaterally. A blunt-tipped curette handle was inserted through the closed introitus to apply pressure as a guide for identifying the appropriate junction point. Before dissection, the bilateral ureteral tracts were identified and traced. High magnification ensured clear visualization and precise mapping of the ureters, preventing injury during dissection. Starting with posterior peritoneal dissection is pivotal, as it provides most of the peritoneal flap for neovaginal creation. This step also aids rectal mobilization, minimizing rectal injury risk. Additionally, it reduces tension on the rectum and uterine remnants, easing the formation of the neovaginal interior wall and uterine vault. Dissections were performed in a stepwise manner from superficial to deep. Creating the anterior flap involves traction on uterine remnants and precise dissection of the peritoneum along the bladder plane, as the flap is formed from these remnants and mobilized peritoneum. Dissecting the bladder to relieve tension and avoiding sutures near it effectively prevent bladder injuries. After fully dissecting the rectum and extending the rectovaginal space to the perineum, the vaginal remnant near the introitus was identified and opened. The posterior flap was sutured and pulled to the introitus, with the suture ends secured and pulled outward through the introitus using ovary clamps for stabilization, followed by suturing the anterior flap posteriorly and pulling it to the introitus. The suture ends of the flaps were caught with ovary clamps and pulled outward through the introitus for stabilization. The neovaginal opening was created with interrupted 3.0 vicryl sutures, initially securing positions at 12, 3, 6, and 9 o'clock, then using intermediate interrupted sutures to complete the circumference. After widening the canal between the abdomen and introitus, the neovaginal anterior wall was formed by continuously suturing the anterior peritoneal flaps and rudimentary uterine structures. Bilateral salpingectomy was performed. To create the neovaginal vault, 3.0 Vicryl sutures are continuously applied along the anterior peritoneal flaps and rudimentary uterine structures, passing through the rectal serosa while avoiding the ovaries. This suture line is then closed to form the vaginal vault. Careful passage through the rectal serosa is critical to avoid injury. The robotic system's precision ensures accurate traversal of the serosa, allowing the rectum to serve as the neovagina's posterior wall and integrate into the vault via sutures. An essential step in this phase is ensuring that both ovaries are excluded from the suture line, which is continuously passed through surrounding structures to create the vaginal vault. Operative duration was 2 hours 17 minutes. Estimated blood loss of 10 cc. No intraoperative complications occurred. The Foley catheter was removed 4 hours postoperatively. We skip cystoscopy because the bilateral ureters are visible during the procedure, and the suture line is created without using the bladder flap. Rectal examination is not performed because the fine sutures through the rectal serosa are too high to be detected manually. The patient was discharged on the first postoperative day with a soft mold in the vagina. On the third postoperative day, the soft mold was removed and the neovaginal opening was inspected with a speculum for flap vitality and vascularity, which were found to be adequate. On the third day, a medium-sized rigid mold was inserted. And by the sixth postoperative day, the patient was able to self-insert a full-size rigid mold. At the 8-month follow-up, the neovaginal cavity measured 13.4 centimeter in depth and 4.7 centimeter in diameter. The patient achieved full penetration and engaged in sexual activity within 1 month. No postoperative complications occurred. The literature includes studies comparing vaginal dilation with surgical methods and various surgical techniques. However, no comprehensive studies have yet demonstrated the role of robotic surgery or its superiority over laparoscopic surgery. Robotic surgery offers enhanced tissue magnification for precise dissection, reduced blood loss and fibrosis due to minimal cauterization. These advantages enable complex procedures with fewer complications, faster recovery, and greater postoperative comfort, particularly benefiting obese patients or those with intricate pelvic anatomy from prior surgeries.